There you go. It's on now.
Okay. All right, welcome. Today we are going to complete the female reproductive system or female reproductive organ, and then we will talk about the development. Okay, so we are going to talk about babies, basically. I don't know why I put this picture here, anyhow. So it's a intruder there. All right, so let's talk about the female reproductive system. So for this, I want you to remember a few things. So very simple, okay? I'm going to go straight to the point. Number one, the female reproductive system or organs, let's move it away, it's a group of organs, are going to be divided into the uterus and the annexa. Adnexa. This word is very common to be used, so you must remember that. Annexa. So, what is annexa? The annexa are going to be the ovaries and the fallopian tubes. Fallopian tubes. Okay? So when you have an inflammation of the ovaries or inflammation of fallopian tubes, that can be in general called annexitis. So when you hear this word, that means that it's kind of no specific localized. We call this, for example, there's some inflammation in the pelvic area, and you have can be the ovaries and or the fallopian tubes. That is annexitis. Okay. Here we have the. Okay, somebody's coming. Who's coming? I cannot. Okay. Okay, so the inflammation, I'm going to start doing this because annexitis, annexitis, okay? We have the inflammation of the ovaries are going to be called ophoritis. Ophoritis. The itis, inflammation, okay? The inflammation of the fallopian tubes are going to be called salpingitis. Salpingitis. Okay? When you have an inflammation of the nexa, overall, we can call the PID. PID. What is PID? Pelvic inflammatory disease. So that is a direct application of what we are going to talk today, okay? So annexitis is not specific. You are not specifying if this is the ovary or is this a fallopian tube. Could be both, could be one. When you have inflammation of the ovaries, it's called ophoritis, medical terminology. That's one point. And the fallopian tubes is going to be the salpingitis. Salpingitis. The overall, so annexitis is inflammation. But when you said PID means that it's more related to a bacterial infection. So infection, basically annexitis could be just inflammation of the ovary. Could be for many reasons, viral, bacterial, could be basically sequels of previous diseases, etc. The same for iris and salpingitis. So the terminology is very clear here, please. PID is the big umbrella. Is a big umbrella. In this big umbrella, you're going to have the ophoritis, or you have the salpingitis, and these together called the annexitis. But if you go more broad, more broad concept is going to be PID. And PID just involves the recognition of some bacteria or virus infecting the area. All right. So that is that, about this division, and we are going to get focused now in the uterus in one by one of ovaries and eggs and the fallopian tubes. Okay, the uterus is going to be a pear-shaped organ that is going to measure about 6 centimeters long. 4 to 5 and 3 to 4 in the other dimensions. So please, how many of you measure your finger? Do you measure a finger? Remember, I was telling you at the beginning to measure your finger. Measuring the finger is going to. If I will be in the school, I will go with my measure, and I'm going to measure each of your finger. Why? Because that is a reference. So you have an idea. So you need to visualize things, and that is helping. Okay? All right, 6 centimeters is about the size of the pinky finger, and that is the uterus. So it's not that long. Can you imagine? This is like this, uterus. But this uterus, can you imagine, is going to elongate to 42 centimeters during pregnancy, from 6 centimeters to 42 to 45 centimeters long. So it's like 7 times longer. So what does it mean? Imagine how amazing is that. Do you know what is your biceps, right? Your biceps? You know what is
Yes.
your biceps? Okay.
Yes.
Good. Now, I want you to, I want to extend stretch out your biceps 7 times. Hard, right? Can you imagine your biceps and pull it 7 times longer than it is? That is what is doing the uterus. Amazing, right? Okay. So the uterus is a pear shape that is going to be 6 centimeters long, and the uterus are going to be divided in many compartments. Okay. So here we have the layers, I will say the division. The division will be the fundus. All this is the fundus. The fundus. All this is the fundus. Then we have the body. This is the body, fundus, and the body is the largest portion of the uterus, the largest part of the uterus. Then we have below that, we have a structure that is called the cervix. This is the cervix. Fundus, body, and cervix. Cervix, that in other words is called the neck of the uterus. It is going to measure about 3 centimeters long. We don't care about that. Okay, so here we have the division of the uterus. We okay with that? Everybody's clear on that?
Yes.
Yes.
Okay.
Yes.
All right. So now let's talk about the layers of the uterus. The layers of the uterus. So, okay, so we have division. Division will be fundus, body, and cervix or neck of the uterus. The layers of the uterus will be 3 layers. 3 layers. We have here, this is the uterus, and here the inner layer that is basically you put your finger inside the uterus, all what you touch, that is the lining. And this lining is called the endometrium. Endometrium. Then we have the thickest area, that is the middle layer of the uterus, that is called the myometrium. Myometrium. So the cervix is part of the uterus. They have a very thin muscular layer too. Okay? Myometrium, endometrium. And we have the outer layer that is called the perimetrium. Metrium means uterus. Peri means around the uterus. Metrium means uterus. Endo means inside the uterus. Myo, metrium. Uh, Metrium means uterus. Myo means muscle. And that is a smooth muscle, as you can tell. You cannot move your uterus, right? Can you move right and left? You cannot, because myometrium is a smooth muscle, okay? Involuntary muscle. You okay with that?
Yes.
Okay. So now I want you to think about this. You see the uterus, like I draw it like this, correct? Okay. This uterus is going to be a virtual space or real space. A real space will be a real space is when you have a tube and you can look like this. But a virtual space means that there is a space here, but the walls are very close to each other, like this. Okay? So the uterus is a tubular organ, but it's a virtual space. It's not a real space. You cannot see the uterus and look like a telescope. No, because that is basically the walls, the anterior wall of the uterus and the posterior wall are going to be in contact to each other. You okay with that?
Yes.
Excellent. All right, so let's go to the pictures. So, all right, so I need to explain you about
Wait, can you go back really quick? Sorry.
Oh, go ahead. What? I didn't hear you. What you
Can
said?
you, can you just hold that picture for 1 second? Sorry. I'm just writing down the last one.
Okay.
Thank you.
Okay, perfect. So now let's talk about the ovary. Okay, so how many ovaries we have? Oh, well, girls have 2 ovaries, right? Okay. So for this, some of you just try to project yourself, visualize. When you probably you were pregnant already, or you're not. You will be some day, and you go to ultrasound and they check the baby, how it's moving. We are going to talk about that today. I just want to remind you, I'm an OBGYN a doctor, surgeon for many years in Peru, C-sections like crazy many times. In addition to that, I have a specialty in OBGYN ultrasound, so high risk pregnancies. So we are going to have a very interesting topic today. But before that, I need to just give you what is an ovary, what is the story of the ovary, and all that, because this is going to be important. Number one, when you are in fetus, you have production about 4 million ovules. So I will say something, because you're going to read some words like oocyte, primary oocyte, secondary oocyte. We are going to talk about the ovule. So basically, when you see oocyte, it's a young ovule. So I'm not going to ask you what is oocyte, okay? I'm not, because I'm saying that because there is some textbooks you're going to read oocyte, and then suddenly they change to ovule without telling you what is this. And basically, it's the same. Oocyte is a very early stage of an ovule. And ovule is the already developed ovule. Okay, the ovule is not going to be completely developed until they get ovulated. So after ovulation, even after ovulation, means when the ovule is outside of the ovary, that is going to complete the maturity of the ovule. Not until then. So all the rest of the ovules, all sites in the ovary, are still in development. Okay? All right. So in conclusion, when you see oocyte and ovule, think about ovule, period. In order to not get confused. You okay with that? All right. So we have 4 million ovules. At the time at time of birth, you're going to have 400,000 ovules. So they are going to decrease. What happened? They are going to reabsorb, blow up, and just reabsorb as a fluid. Then in the puberty, I will say you start the menarche. That is the first word that you need to remember. Please, open eyes, open ears, we're menarche. What is menarche? What is menarche?
First menstrual period.
First menstrual period, right? It's the first menstrual period. That is, at that time, the female is going to go having only 40,000 ovules. So can you see from 4 million, they go 10 times lower, 400, 100 times lower, it's 40,000 ovules. This is the pool of ovules that you're going to use during your menstrual cycle, 40,000. But they said, oh my God, I'm going to ovulate 40,000 times? No, right? So you are going to ovulate only 525 times in your span life. Okay? 525, 26. So from this, how we can explain, so what happened with the rest? Okay? And that is what I'm going to explain you now. Okay, look at this. Here we have the ovary. And the ovary, these young ovules are going to be here. Can you see the cells? So this is the cell and this is the nucleus, all right? So because the ovum is what? Is a cell. And the cells, they have what? A nucleus, correct?
Yes.
Just remember, the ovum is going to have 23 chromosomes only. So that means N chromosomes, bioscience. That is called haploid. It's bioscience again. Okay? Haploid N cells or 23 chromosomes is the same. Same happened with the spermatozoid. Just remember, spermatozoid is a gamete called gamete. And the ovum is another gamete. So when you said gamete, this is question for the exam, gamete means or spermatozoid or ovum. You okay with that?
Yes.
Okay, perfect. So now, from these, all these young ovules that are located sleeping, they're sleeping. They're sleeping. They're sleeping. All of them are sleeping. During one day of the month, some of them are going to wake up. Yes, some of them are going to wake up. How many are going to wake up? They are going to wake up about 10 to 12 of these ovules. Wake up. Oh, yeah, we need to do something. 10 to 12. From these 10 to 12 ovules, 11 are going to reabsorb. 11 are not going to make it. 11 are going to be actually stay in the ovum and be dissolved. And only one ovum are going to be released. The span life of a menstrual cycle is going to be, for example, you're going to be menopause. You know menopause? What is menopause?
No longer ovulating.
No menstrual cycle, right?
Menstrual cycle.
No menstrual cycle. Because bleeding, that doesn't mean ovulation or no ovulation. So no menstrual cycle. No menstrual cycle. So there is no bleeding at all. Okay? So this menopause is going to be 12 consecutive months. That is when somebody gets into menopause. 12 consecutive months. So you stop your bleeding, and actually you start bleeding again at 11 months and 30 days. One spot, one strain of blood. You need to count again 1 year. So 12 consecutive months without bleeding. Okay? The average age, I'm going to start doing that. Average for menarche is in United States is 12.7 years old. So that is your first menstrual cycle in United States is 12.7 years old. Okay? In other areas, more we don't know why, hot areas areas where there's too hot countries that we have high temperatures. Mostly the menarche can start at 10, 9, even 8, 7 years old. Okay, so we don't know why, but the temperature is actually making the menarche appears earlier. And the average for a menopause, the average for, oh, sorry, my God. And the average, where I am, where is my pen? Okay, and the average for menopause is going to be 51.2 years old. Okay, so 51.2 years old versus 12.7 years old. Okay, we are going to give you more information later. Okay, so the menarche are going to have some variations. So you remember, or probably you can see, that when a girl starts the menarche, the next 2-3 years are irregular bleeding, irregular cycles. So the first 2-3 years after the first bleeding, that is irregular bleeding. After 2-3 years, because there's a fight between hormones, estrogens and testosterone, that are going to be finding an equilibrium about 2 to 3 years. Then you can become regular. There's other people that still some irregularities, but that is the general rule. Second, the menopause. The menopause, you start to have problems, or you start to think that the menopause is coming when you have a regular bleeding. So every month you have this time, between these days, I have my menstrual cycle, and 2-3 years before to establish completely the menopause are going to have irregularities. So menarche, first bleeding, 2-3 years is going to be irregular after menarche, of course, right? And menopause is going to be irregular 2 to 3 years before the menopause appears. You okay with that?
Yes.
Okay. Apply everything about your people, your friends, your family around you. So always apply that. Second, the menopause is going to be progressively happening, but at 55, every single woman should be in menopause. Okay? At 55, nobody should be bleeding. At 55. We okay with that? And if that is telling you, is there is some bleeding there, something can happen, something wrong can happen. Okay, the majority of bleeding after 55, you don't need to be afraid, but you need to be careful. That is benign, basically a benign, because the uterus become more thinner and start to break some vessels. So anyhow, but other percentage that is the less common is going to be some malignancy. Okay, so based on that introduction, let's talk about the ovary and the elements of the ovary. All right, so let me see if I have a picture here. There you are. Okay, what is this? Oh, these are the ovaries. Okay, so I was trying to do this in the past. Okay, anyhow. So here we have the ovum, the ovary, and here we have the ovules, or oocytes. See, they're arriving. So what I'm trying to tell you here, what is the ovary? Ovary is the parking lot. The ovary is not the one who creates the ovules. The ovary is just the parking lot. Imagine the parking lot of the school. The school parking lot is the ovary. What are the cars? The cars are arriving to the parking lot, and they are going to be parked in the parking lot. So those cars are going to be the ovules, because the ovules originally they are going to start forming in the stomach, in the yolk sac. So that in the lining, that is really where it starts. There are some cells that are going to differentiate, and believe it or not, it's true. They are going to migrate and populate the ovary, that is the parking lot. Okay, so what happened? The ovules are going to populate the ovary, and there are going to be about 40,000 of these parking lots. Then after that, what happened? It's going to be they're going to sleep for many years. They're going to sleep for many years. And at the time of menarche, at 12.7 years old, there's a migration of some of these inside the parking lot. They are going to move about 10 to 12 of these ovules. They're going to wake up, and then what happened? Look at this. Okay. Here, I will mention here this to make it easy. So parking lot is the ovary. The cars are the ovules. Now, these ovules are going to be surrounded by cells like this. These cells in red are not ovules. These cells are going to be called the follicular cells. Follicular cells. The follicular cells. What is reminding you? The FSH, anterior pituitary gland, adenohypophysis, FSH, GPTAL-F, FSH, follicular stimulant hormone, right? So this follicle, for FSH, what they are going to do is to produce the proliferation of the follicular cells. Look at this. So these folliculars is like, go to the parking lot, you see your car, and somebody put balloons around your car. Your car are not the balloons. The ovum are not going to be the follicular cells, are going to be associated with, but it's not the ovum. So the follicular cells are going to be surrounding the ovum. So here we have the ovum, here we're going to put an O, and you can tell the follicular cells, and that is the reason I'm explaining that, plus the ovum is equal to, say, the follicle. So when you see in ultrasound this kind of black area, you see the ovary in black area, like a small balloons there. So that is a follicle. You obviously you will not see in ultrasound the ovum itself, but you see the whole structure. So we have the ovum plus follicular cells are going to be called a follicle. What is important about this follicle? This follicle is the follicular cells. Listen, the follicular cells are the one who produce estrogens. So the ovum itself do not produce estrogen. The ovum do not produce estrogen. Yeah, it's true that we said the estrogens are being produced by the ovary. Yes, because those cells are in the ovary. So that's why we said the ovary produce estrogens. But these estrogens basically are going to be formed by these follicular cells. So what happened? Here we have the FSH, the follicular stimulant hormone, and that is going to make proliferation of many of these follicles, making the follicular cells surrounding the ovum. It's coming more FSH, more than FSH. What happened? You're going to add more layers, 2 layers, 3 layers around the ovum. So there are going to be more and more layers of follicular cells. And that means that during the menstrual cycle, you have more and more and more estrogens. So that's why the estrogens are going to be low at the beginning of your menstrual cycle and are going to be high in the middle of the cycle. Why? Because the FSH, that is the follicular stimulant hormone, is the one who stimulates the follicular cells to produce more number of follicular cells and more estrogens. You okay with that?
Yes. Yes.
Okay. So remember I was telling you in the past that we have, this is day number 1, this day number 14, this day number 28 of the menstrual cycle. The estrogens at the beginning are going to be low, right? And they're going to be increase. And then on day 12, that's English exam, day 12, no 14, the estrogens are going to start going down. And that is needed in order to produce the ovulation. So if you don't have the estrogens going down, ovulation will not happen. So estrogens in day 1 are going to be very low. The FSH is coming and they're going to make proliferation of the follicular cells more and more. So the levels of estrogens, day by day, they are going to increase. When they go to day 12, when we have the highest, day 12 is the highest level of estrogens. Question for NCLEX. Highest level of estrogens. What happened after day 12? Day 12 start to go down. And that is going to allow the ovulation. And what happened? From these 10 to 12 follicles that are being progressing, they are going to dissolve. 11 of them. 1, 2, 3, 4, 5, 6, 7, 8, 9. Then only one will survive. And when you destroy when these are being disappear, all these ovules with the follicular cells, the estrogens are going down because are the follicular cells who produce the estrogens. And that is only one ovule will be released. Okay? You okay with that?
Yeah.
Yes.
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 All right, so what is the concept about what I just mentioned? The concept what I just mentioned is that the estrogens are going to be stimulated by the secretion of FSH. Remember? FSH, GP-TAL-F, is going, the target organ will be the ovary. What is the function of the FSH? Is going to be the production of estrogens through the follicles. Okay? Follicle are follicular cells. These are follicular cells. And the ovum inside, all this is called follicle. Period. Nothing else. Follicle. But these cells around are called the follicular cells. That is what we call. Okay? All right. We okay with that? Okay. Before going to again to the menstrual cycle, if you see here, look at that. So there are going to be, here we have many babies, ovules, they are going to develop. They are going to show you only one, but they are going to develop between 10 to 12. They're going to grow. And then what happened? They're going to release one ovule. The rest of the ovules that will develop will disappear. You only release one ovule in general. Okay, there's twins, triplets, whatever. That is another story. But yes, in general, you release one ovule. Okay, we got it.
Yes.
Yes.
Okay, perfect. All right. So what else? Okay, I'm going to talk to you about the. We talk about the uterus, about the fallopian tube, and now it's time of the fallopian tube. This is the fallopian tube. The fallopian tube is going to measure about 12 centimeters long, double size of the uterus. It's like a spaghetti, spaghetti. So I did a lot of ligations in the past. It's 15 minutes surgery only. And what happened, we just ligate, so means make a knot here in order to block the transportation of the ovum. And what happened is, what happened with the ovum? Yeah, the ovum will be reabsorbed, means destroyed. So they are going to live certain time, and they are going to blow up and reabsorb. So there is no problem with that. All right, so the fallopian tube, is a tubular structure that is going to measure about 4 millimeters thick, and the lumen is about 2 millimeters. Very thin, So, but it's plenty space because the ovum is going to be measured. One ovum is going to be 1/10 of a millimeter, 1 millimeter, and the tunnel is going to be about 2 millimeters. So it's going to be about 20 times the space. It's like you have 1 meter and you have 20 meters to run through. So you have plenty space to go through. All right, so this ovum, the ovum, when it's released, the ovum is going to get trapped or attracted by the fallopian tube. Can you see these lines here? This is called the fimbria. Fimbria. Fimbria are like a finger, So what is doing the fallopian tube? The fallopian tube, we have, remember the fallopian tube I mentioned before, they have the smooth muscle, right? A smooth muscle. And this smooth muscle have peristalsis. So what is doing the fallopian tube and the fimbrias are going to do this? Come ovum, ovum, come ovum. And that creates a current where when the ovum is being released, it's going to be basically vacuum absorbed by the fallopian tube. Okay? It's like something like that. Okay? So that is what is doing the fallopian tube. The division of the fallopian tube will be the infundibulum, and the infundibulum, please, this is a wrong picture here. The infundibulum is going to be all this. That is the infundibulum. Infundibulum. The infundibulum is going to have a component that is the fimbria. The fimbria belongs to the infundibulum. You okay with that?
Yes.
Okay. Then we have the ampulla. The ampulla, question for exam, is the largest or the longest area of the fallopian tube. The longest area of the fallopian tube. Here is what happened, the fertilization. That is when the spermatozoid is going to find the ovum. So that is the ampulla. The ampulla is where basically the fertilization occurs. The fertilization. Write down this. Fertilization is the same to say fecundation. Fecundation. Okay, fecundation. All right. Or called conception. There is different names. Conception. So you need to remember very well. So fertilization, fecundation, or conception. And what is this? Is the fusion of the gametes. Fusion of gametes. Gamete. What is a gamete? A gamete is a spermatozoid or an ovum. Fusion of a gamete. Fusion of the gametes. So that is having a name, technical phymixis. I'm not going to go on that. The fusion of the gametes. And that is going to lead into one cell that is called the zygote. The zygote. Question for exam. Zygote. Zygote. So what is the zygote? Is the fusion of the gametes. What is the zygote, please?
Fusion of gametes.
Fusion of the gametes. And where this fusion happen?
Ampulla.
In the ampulla of the fallopian tube. You okay with that?
Yes.
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 Okay. Zygote. Don't forget that, please. Okay? Okay. Then we have the isthmus and we have the interstitium. This is the uterus. Look at it. Very, very good. This is the uterus, and the fallopian tube is going to be like doing like a channel, like a tunnel through the uterus in order to evacuate or pass the ovum into the uterus. You okay with that? Okay, perfect. All right. So now we are going to talk about that. Okay, the position of the organs, the neural organs in female reproductive organs. So look at this. Here we have the urinary bladder. This is the urinary bladder. Urinary bladder. Posterior, we have the rectum. And in between, we have the uterus and the vagina. If you pay attention here, the uterus is going to use the urinary bladder as a pillow. See, it's like it's going to lay down over the urinary bladder. So that's why when you get pregnant, the uterus start to get enlarged. And this enlargement of the uterus is going to compress the urinary bladder. And that's why you want to pee more often. You okay with that?
Yes.
Yes.
Sometimes when the uterus, the position of the uterus is retroverted like this, sometimes they can push the rectum. And some women are going to having problems with constipation because the uterus is going to press the rectum. They can have constipation. Okay? Depends, there is different positions of the uterus. That is the most common, that what we call the antevertebrate. So it's like this. Okay? Laying down over the urinary bladder. We okay with that? All right. So now another important thing that you need to always remember is the anatomical position. So we have here, this is anterior and this is posterior. All right. So here we have we have posterior, we have the anus. More posterior, we have the anus. More anterior, we have the urethra. More posterior, more anterior is the urethra. And in between the urethra and the anus, we have the vaginal canal, the vagina. Okay, the vagina. So why is that important? That is very important because, and you will see when you make a mistake. You will see. You remember me. It's very. You don't want to make that mistake, but you need to be aware because of this. So you're going to put Foley catheters. You know what is a Foley catheter, right?
Yes.
Okay. Do you put Foley catheter already in clinicals?
No.
No, not yet.
Okay. So the Foley catheter is in order. They're going to be Foley catheter is going to put it in the urinary bladder. In the urinary bladder. Okay, that is the Foley catheter. Some people, by mistake, they put it on the rectum because they say push, push. Oh, some opening is coming in. All right, so that should be. No, it's not like that. Some people put it on the vagina. Some people put it in the vagina, and that is wrong because you're going to have the Foley catheter for a reason. And worse, some people think that the urethra were supposed to come the Foley catheter. They thinking is the clitoris, and they're pushing, 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 and that is going to make hurt the patient. Okay, and why is that? It's so silly to make a mistake. No. I saw many. Something that happened to me, but you're not going to see patients of 100 pounds or 150 pounds. You're going to see patients of 300 pounds, 400 pounds sometimes. And to put a Foley catheter is very challenging on that. It's very challenging because you cannot see anything. Everything is surrounded by tissue, fat. Okay, so you need sometimes to put, literally, you need to put the belly on your shoulder and push, and somebody help you in order to be able to see something. So you need to be careful on that. You okay with that? So what is the distribution of that? More anterior, we have the urethra. In the middle is the vagina, and posterior is the rectum. And more anterior is the clitoris. Okay, it's very sad to have somebody making those mistakes, especially with the clitoris. You okay with that?
Yes.
Yes.
Okay. Excellent. All right, so now let's talk about the menstrual cycle. The menstrual cycle. All right. When we are talking about menstrual cycle, I want to tell you something. So the menstrual cycle, classically in the books, is going to be is going to be 28 days. 28 days. That is the classical. But if you see your example yourself, for example, you are not having 28 day cycle. Okay, listen to this. Write down this, please. Only 15% of female, 15% of female are regular 28 days. 28 days. And that is what standardized in the textbooks and all that in order to standardize the how to explain the menstrual cycle. Okay, 28 days. Can you imagine 28 days. 28 days is coming basically is coincidentally with the number of days of the moon cycle. The cycle of the moon is coming 28 days, and most happen in the full moon is where most of menstrual cycles occur. And why is that? Who knows? We cannot tell. There's a lot of investigation we don't know. Now, let's go back. Gerald, you're looking at me. Look at this. Let's go back, Gerald, 10,000 years ago in the history. So imagine I'm teaching with the skin of animals, with my stick, whatever. There was no computer there, of course, right? But everybody was no cell phones, no TV, no media, nothing at all. So you just walking on the valley, looking for food, right? And can you imagine that one thing? Do you know that women that are living together for a certain period of time, 3 months together, 4 months together, they menstruate the same day? Right? So a group of females who are basically living together for a certain time, 2-3 months minimum, you start to have your menstrual cycles are going to synchronize. They're going to say, oh, yeah, you're bleeding. Yeah, I'm bleeding too. Okay, so that is basically what happened. Okay, now imagine now 10,000 years ago. We don't have shoes, nothing. And the tribe. And suddenly all female in the tribe start to bleed. So what's going on? Right? Oh my God, it's crazy. Oh my God, all women are start bleeding. So something is wrong here. What's going on? At that time, do you know something about anatomy? At 10,000 years ago, you knew about utero, fallopian tube, and nexa, whatever. Nothing. We don't know nothing, right? So at that time, so what happened? So it's very human that when you cannot explain something, when you cannot explain, it's like a mystery, like a magic. You always think that is somebody more powerful than you is doing that. So that was the actually belief in gods. Okay, and what happened? They were saying the moon is appearing, everybody is bleeding. Oh, the moon is a god, and what they are doing? They're asking. They said, "Oh, the god is asking for some present in return of what she's giving us." So they were thinking that the blood was a requirement of the god in order to give some kind of price to the gods, right? And that's what they believe, that the gods were asking for blood in order to, like a gift for them, like say thank you for everything. Okay, and that's why later on, when you have some catastrophes like storms, like earthquakes, okay, or actually eclipses, whatever, they were thinking that the gods were upset and there was not enough blood. So that's why came the sacrifice of human in order to bring blood to the earth, touch to the ground. Interesting, right? Now, thank God that we are not living in a cave right now. We have internet and we have cell phone, right? We have our car. We was not walking or using horses anymore. So yeah, so we are in that time. Okay, so that is about the menstrual cycle. Remember, the menstrual cycle in the United States is 12.7 years old. Menarche is the first menstruation. Okay, and one more thing I want to tell you is this: that we need to know the LMP. So please, LMP, 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 LMP. What is LMP? You're pregnant. You were pregnant, probably. The last day, the last menstrual period. The last menstrual period. You okay with that? And when is the last menstrual period? Please, this is huge. Why is it important to know that? Because they need to know, listen to this, they need to know how many weeks of gestation you are. Why they need to know that? Because at this gestational age, the baby should be having some size. So they are going to tell. They are with the LMP. They are going to know how many, what is the development at that time of the baby. If you don't know the LMP, you will not know if the baby is growing slow or growing too much. See what I mean? And the LMP is critical in order to know how much is that gestational age of the baby. And the last menstrual period is the first day of blood or bleeding. Is that clear or not?
Yes.
The first day of bleeding, not the next day, not the last day of the bleeding. No, the first moment you see a spot in the underwear or bleeding, they are going to, because that is the LMP. And that is the data that you need to give to the doctor or to the sonographer. We okay with that?
Yes.
All right. So I put the basis in order to tell you what is the menstrual cycle now. Okay.
Dr. G, can we take a break before we go into this?
You want a break? No,
course.
no. Okay. Let's make a break. See, I was already ready to jump.
It was warming up.
Yeah, warming up. Okay. I will see you at 10:56. Thank you for letting me know. Okay.
Thank
Thank you.
Thank
Thank
you.
you.
Get ready. Okay.
Yeah.
Hello.
Stop that.
All right, so let's start. Let's get started. Okay, let me see if I have this one. Okay. All right, so here we have the cycle of the menstruation. Okay, so here is what happened with the endometrium. This is the endometrium. Endometrium. This is the endometrium. Let's make it simple. The endometrium, this is day 1. This is going to be day 28. So the mid-cycle is 14 days. Here is where happened the ovulation. Okay? All right. So during this period, you're going to have between 1, 2, 3, basically 3 days is the average of bleeding, and they can actually go up to 7 days. That is normal. Okay? So basically, it's going to be about the bleeding will be about 70 to 80 mLs of blood. So that means that is the half of a cup of a coffee. Okay, so that is the volume of bleeding. So each tampon is going to collect between 5 to 8 mLs. So that means total tampons you will use about 8 to 12 tampons during those days. And that means it's important. Why? Because the patient can tell you that he's bleeding more than normal. So you can ask the way to measure that, because you cannot see it, is how many tampons regularly using and how many tampons are using now. So that is giving you an idea of how much bleeding the patient is having. Okay, you got it?
Yes.
Hello? Okay. So now, what happened here is that when you are not pregnant, oh my God, everybody's making noise. When you are not pregnant, what happened that endometrium is going to slough off. They are going to just get out. So, and that is going to be, the endometrium are going to be very thin, very thin. And that thing is going to be about 4 millimeters thicker, 4 millimeters. And they can reach about 14 millimeters during the thickest area. So it's going to grow about 1 millimeter per day. Anyhow, so what happened here? So look at this. The endometrium start to get bigger, thicker. And that means that there's going to be proliferation of these vessels. Proliferation. That proliferation of vessels are going to bring more and more blood and more nutrients, because you are preparing your uterus for a possibility to get pregnant. Now, this is the proliferation process, the proliferation of vessels. Okay, that is the first 2 weeks. In the next 2 weeks, so 12 days, 12 to 28 days, 14 to 28 days, there are going to be what we call the secretion. The secretion is going to be the deposit of glycogen. Glycogen. This glycogen is going to make it even more thicker than endometrium. This glycogen is used as energy, because eventually the ovum that is fertilized by the spermatozoid are going to get into the endometrium. And when that happens, is the endometrium is ready, prepared to give the nutrients, the glycogen, glycogen polysaccharide are going to be a big molecule of glucose. So they are going to give energy to the actually the division of the egg. Okay, so now this is what we call in the endometrium. In the endometrium is having the 2 phases: the proliferative phase, proliferation of vessels, and then is coming the secretory phase. We okay with that?
Can you repeat that again? I'm sorry.
Yeah. So the first 2 weeks is the proliferative phase. Proliferative phase, I'm going to write it down here. That is called the proliferative phase. Proliferative phase. And then we have the secretory phase. Okay? The secretory phase is glycogen deposit, and proliferative phase is basically the proliferation of vessels. More vessels, more oxygen, more nutrient, preparing your uterus to get pregnant. Okay? The proliferative phase are going to continue. Yes, all the way. It's going to start here in the first 2 weeks, and they're going to continue. But what is in addition happen after the after 2 weeks is going to be the secretory phase, where they are going to get deposit the glycogen. Is that clear?
Yes.
Yes, thank you.
Yes. Okay, perfect. So now, if you see here, this is at the level of the uterus. But there is something that is happening simultaneously on the ovary. On the ovary. Simultaneously. So that's why they are coming correlation, all these pictures. So at the beginning, you're going to recruit follicles. So this blue, and the dot here is the ovule. And the dark area around are the follicular cells. You okay with that? So it's like the car surrounded by balloons. So this is the cell, this is the cytoplasma, and the nucleus here inside, that is the ovule. But then you see this dark area around, those are the follicular cells. So altogether, it's going to be called a follicle. So from these are going to proliferate, they're going to grow, they wake up 10 to 12 of these follicles. And they're going to grow and grow and grow and grow. So in the next few days, what happened, what happened is that is released by are going to stimulate by the FSH, the follicular stimulant hormone, the FSH, the FSH, the FSH. And when the FSH is going to increase, the FSH is going to increase when the estrogen levels are very low. She said, oh, the hypothalamus said, oh, you have low estrogens. Oh, okay, so we need to increase the estrogen levels in the blood. So the FSH start to be produced by the anterior pituitary gland, target organ, the ovary, and they are going to grow 10 to 12 of these follicles. Then the FSHs keep coming, and from these 10 to 12 follicles, they are going to start growing. Can you see here? More cells. So they are going to add more and more cells because it's proliferation of follicles, the follicle cells. More follicle cells produce more estrogens, and more estrogens, and more estrogens, and more estrogens, and more estrogens. If you see here, estradiol is an estrogen, and the estrogen at the beginning is very low. That is where it's coming the FSH, because you said, oh, I have too low levels of estrogen. Let's produce FSH. FSH, what it's doing is waking up 10 to 12 of these follicles, making even more follicular cells getting around the ovule, more balloons around your car, more and more balloons. And each balloon is the one who produces estrogen. So the estrogens are going to start going up. Is at day 12. At day 12, you see 12 here. Day 12 is the highest level of estrogen. Question for NCLEX. Highest level of estrogens is at day 12 when the hypothalamus is saying, oh, you already reached a lot of estrogens, so we need to decrease the estrogens. So you need to go down with the FSH. So the FSH starts to go down. And that is going to make production of the LH. So LH, remember, LH, target organ, the ovary, LH, ovary, target organ, and the function is to produce the ovulation. The LH is produce the ovulation. It's coming the LH here, and the LH is coming when the FSH is down, because the LH can be produced only when the estrogens start to go down. And that is where the moment is going to happen, the ovulation. So at day 12, where the highest level of estrogens occur in your body, hypothalamus is going to say, too much estrogens. Okay, decrease the FSH. And that process produces the increase of the LH, ready for the ovulation. So at day 12, FSH go down and LH start to go up. That time is needed in order to, at day 14, is going to happen the ovulation. You okay with that?
Yes.
Okay. Now, from this 10 to 12, the ovulation, that means that only one of the follicles will release one ovum. The rest are going to be reabsorbed. And because of this reabsorption, because of the low levels of FSH, that is going to be down the level of estrogens. And that is going to allow the LH going up, and that what causes is the ovulation. The ovulation. Okay? All right. So now the proliferative phase is going to be based on the levels of estrogens. So what is doing the estrogen? Question for the exam. Estrogens cause the proliferative phase in the endometrium. Estrogens cause the proliferative phase in the endometrium. And that means the proliferation of vessels. Okay? This phase on the endometrium is called proliferative phase, but the phase on the ovary is going to be called the follicular phase. The follicular phase. The follicular phase. So there is two events happen simultaneously. The follicular phase, that is the proliferation of the follicles in the ovary, and the more proliferation produce more estrogens. Those estrogens go to the uterus to produce the proliferative phase of the endometrium. Is that clear or no? Hello?
Yes.
Yes.
Okay, perfect. Now, when the ovulation occurs, when the ovulation is going to happen, the ovum is going to be released. The ovum is going to be released. But the follicular cells are going to stay in the ovary. The follicular cells are going to stay in the ovary. These follicular cells are going to actually, it's like a pimple. You open a pimple, the ovum is coming out, but the tissue is going to stay in your skin. So similar thing happen with the follicular cells. These follicular cells, they are coming and form what we call the corpus luteum. Corpus luteum. So the remnants, after the release of the ovum, the remnants of the follicular cells who stay in the ovary are going to form the corpus luteum. The corpus luteum. The corpus luteum in the ovary is going to give the phase, what we call the luteal phase. The luteal phase in the ovary. That is the luteal phase in the ovary. What is doing the corpus luteum? The corpus luteum produces progesterone. And this progesterone is the one who produces the secretory phase. The progesterone is coming from the corpus luteum. And the progesterone, what it's doing is the secretory phase, means the deposit of glycogen in the endometrium. So just to summarize here. To summarize here, we have the first 2 weeks, 1 to 14 days, 2 weeks. So here we have the proliferative phase, and here in the ovary, we have the follicular phase. The follicular phase. So that follicular phase is commanded by the FSH. The FSH are going to send orders to the ovary to proliferate follicles, wake up 10 to 12, and they are going to accumulate more and more and more follicular cells that produce estrogens. So the estrogens start to go up. The estrogens that produced in the follicular phase by the ovary, these estrogens are going to go to the endometrium. And in the endometrium, the effect of the estrogens in the endometrium is the proliferation of the vessel. That's why it's called the proliferative phase. Then at day 12, the estrogens start to go down. It's a negative feedback. So you have too much of something, they say, okay, too much, let's slow down. So they're going to decrease the production of FSH. They are going to disappear 11 of the follicles, and it's going to be only one follicle who release the ovum. That is the moment where the estrogens are going down, where the LH is going to surge. The LH is going to be produced by the pituitary gland, right? And the LH, what it's doing is the ovulation, the release of the ovum from the follicle. The ovum is going to go to try to find the spermatozoid. Meantime, the remnants of the follicle are going to produce the corpus luteum that is the luteal phase because it's after the LH, the luteal phase, the luteal hormone is after, that's why it's called luteal. And these luteal hormones the luteal phase produce the progesterone. And the progesterone are going to go to the endometrium to produce the secretory phase. The secretory phase. That produces the accumulation of glycogen. We okay with that?
Yeah, so the secondary phase comes like on day 14.
Yes.
Okay.
Yes. The secretory phase starts in day 14. You okay with that?
Yes.
Okay. This progesterone are going to basically maintain by the corpus luteum. Corpus luteum is the one who produces progesterone. Corpus luteum produce progesterone. Progesterone go to the endometrium to produce the secretory phase. But the endometrium cannot grow forever. So if you are not pregnant, the progesterone is not going to be enough. If you are not pregnant, that progesterone produced by the corpus luteum is not going to be enough. It's not enough to sustain the growth of the endometrium. If you are not pregnant, at the end of 28 days, it's unsustainable anymore because the progesterone is not produced in big amounts by the corpus luteum. And that is going to make a slough off the endometrium. And they are going to start your menstrual cycle again. You okay with that?
Yes.
Okay. So what happened? So that's why I'm telling you, when somebody have OCP, oral contraceptive pills, when you have oral contraceptive pills, basically what they are, those are estrogens. So you're taking pills every day for estrogens, and estrogens are going to increase, proliferative phase, are going to increase the endometrium, proliferative. So, but on the day of the day 12, we're supposed to be the estrogens down, you're still taking OCP. So your levels of estrogens are going to be always high. And that means that if you are always high with estrogens, the LH will not be produced. So ovulation will never happen. So if you have, so the estrogens, in order to occur ovulation, they need to go down in the mid-cycle. If the estrogens are going to keep high, ovulation will not happen. Okay? If somebody is taking OCP, you will see, but I'm still bleeding. But bleeding is a small bleeding. There is a small bleeding. Why? Because the endometrium was actually thicker because of the proliferative phase. There is no secretory phase, of course, because there is no corpus luteum. But what happened is that this is going to get thicker because of OCP, and they can slough off because it's not sustainable for a long period of time. And the bleeding is small. Yeah, there is bleeding. Some people who are taking OCP, they're still having some bleeding, and they think that I'm ovulating. No, there is no ovulation. If you follow every day, the same hour, the pills of the oral contraceptive pills, there is no way to be actually pregnant. Okay, we got it? It's 99% effective, the OCP. The 0.01, that is because you make an error to take the pills. We okay with that?
Yes.
Okay.
Yes.
So now, so when you are getting pregnant, when you get pregnant, okay? When you get pregnant, we have the encounter of the spermatozoid with the ovum, correct? With the ovum. This is a gamete, a spermatozoid, another gamete, ovum, and they are going to produce a big cell that is the combination of N and N. So haploid 23 plus 23, this product is going to have 46 chromosomes now. This is called the zygote. And that is called egg. All right, so that is the fertilized egg, or sometimes we call the fertilized egg. These zygotes are going to have the 46 chromosomes, zygote. These zygotes are going to produce they are going to divide in 2 equal cells. And then they are going to divide in 4 equal cells. Then they are going to divide in 8, 16, 32, 64 cells. And these 64 cells, from this cell is coming your eyes. From this cell is coming your foot. From these cells is coming your nose, your spleen. So each of these cells, and that is amazing, from all equal cells, in some moment they are going to differentiate because of the DNA message. They are going to differentiate in different parts of your body. So that is the origin of us. Okay? Now, what happened? You already know what is the pregnancy test, right? Pregnancy test. What is a pregnancy test? What are going to measure the pregnancy test?
HCG levels.
HCG levels. What is the HCG levels? The human chorionic. Chorionic is where it's coming the placenta later on. A gonadotropin hormone. Okay? So this HCG, human chorionic gonadotropin hormone that you take in the urine to have a pregnancy test, is produced by these cells, by the zygote. The zygote are going to produce, at the beginning is going to be one cell. They are going to produce HCG. Then it's going to divide in 2. They are going to double the HCG. Then are going to divide in 4. They are going to basically double again the HCG. And that HCG elevation are going to go to the blood, go to the urine, and you have a pregnancy test. So the HCG is coming from the fertilized egg. The HCG is coming, I put it more colloquial, coming from the fertilized egg. And they are going to duplicate every 2 days. So this division is going to happen every 2 days. So every 2 days, you're going to duplicate the levels of HCG. Now, this HCG is similar to the LH. And this HCG is the one who are going to continue with the secretory phase of the endometrium. So that means that HCG, because the similarity chemical composition with the LH, that the one who produce progesterone, are going to able to continue the pregnancy because of this HCG. And that's when you get pregnant. You okay with that?
Yes.
Yes.
Okay. So what I want you to remember, just a summary here, we have menstrual period, 28 days. There is 2 organs who participate in the menstrual cycle. Number 1, the ovary, and number 2, the endometrium. The ovary have 2 phases, and the endometrium have 2 phases. The ovary have the follicular phase and the luteal phase. And the endometrium is having the proliferative phase and the secretory phase. Now, the correlation will be the follicular phase of the ovary correspond to the proliferative phase of the endometrium. And the luteal phase of the ovary correspond to the secretory phase of the endometrium. The day of ovulation is going to be day 14, where what is happening? The FSH go down and the LH go up in day 12. In day 12. When that happens, the consequence of that will be appearing in day 14, where is the release of the ovulation. You okay with that?
Yes.
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 Okay. So now, if somebody is taking OCP, that's why you now understand why they need to take militarily every day and as a better to take it at the same hour. You okay with that? Okay. Perfect. Any question? Okay. All right, so from this, I'm going to talk about some few terms here. This is the amenorrhea. Amenorrhea. Amenorrhea means the absence of menstrual fluid or menstrual flow or menstrual cycle. So there is no blood. Amenorrhea means no bleeding. There is no bleeding, no bleeding, no bleeding. Tell me one thing. If you understand that, challenge you. What is the most common cause of amenorrhea? Amenorrhea means that you're not bleeding for at least 3 months. Okay, write down that. Amenorrhea is when you are not bleeding for at least 3 months. My question, 3 months, 3 months, 3 months. Amenorrhea, 3 months. So what is the most common cause of amenorrhea?
Premenopause.
Pregnancy.
Pregnancy, very well, thank you. Yeah, premenopause sometimes happen. Yeah, it could be premenopause, but the most common, and you were right, the most common is the pregnancy. During pregnancy, you're bleeding? No. No? Okay? We okay with that?
Yes.
Dysmenorrhea. Dysmenorrhea is difficult and painful menstrual cycle. Dysmenorrhea. Dysmenorrhea means painful and difficult menstruation. Do you know those girls who said, oh my God, I'm going to have my menstrual cycle? Basically, they are putting the patient on bed. They cannot even walk. They're not hungry anymore, whatever. 3 days, 4 days with a lot of pain. That is very common when you have endometriosis. Endometrium that is outside of the uterus. Another time I will explain you that. But it's very interesting. But anyhow, so dysmenorrhea, the concept is painful during the menstrual cycle. Painful during the menstrual cycle. Okay?
Yes.
Okay. Now we have the PMS, premenstrual syndrome. The PMS, premenstrual syndrome, is that you notice this, oh my God, don't talk to me. Don't even look at me. Don't pass in front of me. Don't do this. Don't do that. I want to be alone. Give me alone. Give me my space. Right or no?
Wow, that's bad.
Right?
That's mean.
What mean? What mean? Why? But it's physiology that is normal. I will tell you what are the signs and symptoms of PMS. And don't forget that, okay? All right, so number 1, you will see that you have water retention. Water retention. That is happening because of the estrogens. In the estrogen, what it's doing is to retain water. It's retaining water. So, for example, day 12 in the mid-cycle, can you use your pants that you like, or your blouse, or your bra, or your underwear?
Bloating.
You feel that you are totally swollen, right? Yes or no? I say, oh, I don't feel good today, right? That typical, right? Translation, right? No, I don't feel good today, so okay, I'm not in the mood. Oh, okay, probably the PMS, right? Water retention. Then you're going to have insulin resistance. Insulin resistance. What is doing the insulin? The insulin is bringing glucose inside the cell. If you have insulin resistance, you cannot put the glucose inside the cell. So you are starving. That is the time that you start to eat chocolates, candies, ice cream. There is a time on the menstrual cycle that the girl, they want to eat sweets, or no? Yes or no? Do you notice that? Somebody noticing? Not a lot of.
Yes, I eat a lot of sweets when I'm gonna have it.
Yes, there you are. Then we have they are going to have the prostaglandins elevation. Prostaglandins. The prostaglandins are going to, remember, we have pain, inflammation, mucus, and clot. Remember that or no? Remember?
Yes.
Okay. So P prostaglandins, women having high levels of prostaglandins, so become more sensitive for pain. Sounds familiar? Sensitive for pain. Or no? Yes?
Yes.
Right? So everything is more, you're more sensitive to whatever, to the hot, to the cold, right? So that changes your mood too, right? Then we have the endorphins. So prostaglandins go up. Insulin resistance, okay. Endorphins are like opioids in your body. So I have endorphins, you have endorphins, everybody have endorphins. Endorphins is going to basically calm the pain. When you have a broken bone, at the first second you don't feel the pain. After a few seconds, yes. But why? Because you release these endorphins. These endorphins are like make you more resistant to the pain for a few moments. And what happened with the PMS? Endorphins are going down, very down. So you're still sensitive for pain. And the last thing that happened is the serotonin. The serotonin is actually the hormone, the neurotransmitter for mood. You have normal levels of serotonin, you're happy, you are satisfied, everything is nice. But what happened with PMS? The serotonin go down, very down. You feel even depressed those days. Yes or no? Some people doesn't have signs and symptoms more evident than others. And that is what happened with the PMS. We okay with that?
Yes.
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 So now, how you remember that?
Wipes.
Wipes. Water retention, insulin resistance, decreased prostaglandins, decreased endorphins, and decreased serotonin. Increased prostaglandins, decreased endorphins, decreased serotonin. Okay?
Yes.
Okay. So that is about this class. Let's continue to the other. Any question?
No.
Okay. So here we have, without you knowing, I was making shortcuts. So now you're going to be easy for this class. 44 slides, and then we are going to do eye and cranial nerves. Okay. Menstrual cycle.
Yeah, sorry, I don't mean to interrupt you, but we're not having a quiz for this class, so does that mean a large portion of our final will be based on this, like the midterm
Yes,
one?
yes, that's what. Yes, I mentioned that at the beginning. Yes, you're right. Okay. There is no quiz for this. It's going to be included that in the final. Okay.
Thank you.
Sure. All right. So here we have. See, average menstrual cycle is 28 days. 28 days. only 15% of women have typically 28 days cycle. Only 15%. The range is between 21 to 35 days. If you have more often menstrual cycles, that is called the polymenorrhea. And you have more than 30 days, it's called oligomenorrhea. Oligomenorrhea, polymenorrhea. Okay? All right. So we have the first 2 years after menarche, there are going to be an irregular menstrual cycles. 3 years before the menopause, there are going to be abnormalities in the menstrual cycle, irregularities. So that is how it's happening. After your first menstrual menarche, you start to have 2-3 years irregular bleeding, and in menopause 2-3 years before the establishment of the menopause. So this is the circle. Look at this. These are the sleeping ovules. They are going to produce here. Let's see. They are going to wake up and look at this. See, can you see here the follicles? Inside we have the ovule with the nucleus. All this is the nucleus. This is the cell membrane. Can you? And this is the car. The balloons are around. Can you see the FSH is coming here, and the FSH is going to make more number of follicular cells, more balloons around, and that produces more estrogen. When you're going to get close to day 12, the FSH starts to decrease, the FSH, and the 10 or the other 10, 11 follicles are going to reabsorb. So there is no anymore that many follicular cells. So your estrogens start to go down. But only one is going to survive. That is going to produce the ovulation. This ovulation, then these remnants of the follicular cells are going to stay in the ovary, producing the corpus luteum. The corpus luteum is the one who produces progesterone. And this is the corpus luteum very well developed. When you are not pregnant, there is no pregnancy, the corpus luteum get into the corpus albicans. If you touch the ovary of a young woman, it's smooth and very slippery. But if you take an ovary of an old woman, it's going to be like a scar tissue, very rough surface. Why? Because the corpus luteum turns into corpus albicans, and that is actually a scar. Okay? All right, so we okay with that?
Yes.
Yes.
Now, look at this. When the ovary, I will draw here. This is the ovary, and the ovary is covered. I'm going to write it down here. Is covered by some epithelium here. Epithelium, very close, very attached. Epithelium. It's like a membrane covering the ovary. That is epithelium. This epithelium is like the skin. So in order the ovum to be released, they need to break down the epithelium. This epithelium, as you see here, they are going to be break down. They are going to release some blood, some amount of blood. Come on, please, where is that? Is going to release some amount of blood. And you know, the peritoneum is going to cover the uterus, the fallopian tube. The peritoneum is in the abdominal cavity, but there is no division between abdomen and the pelvis, right? So what is in the pelvis is the uterus and the fallopian tube with the ovary. So the peritoneum that is coming like a curtain from the abdominal cavity is going to cover the uterus, fallopian tube, and the ovaries. And when the ovum is being released, they are going to have some drops of blood. This blood is going to touch the peritoneum that is covering all these organs. This peritoneum are going to be irritated and you have pain. That is coming the pain. That is where is coming the pain. The lower abdominal pain, that is because some blood after the ovulation is making irritate the peritoneum produces a diffuse pain. Diffuse pain. We okay with that? Hello?
Yes.
Yes.
Okay. The menstruation go from 3 to 7 days. Average days is 5.2 days. We have the fertile age is 15 to 44 years old. The fertile age. The fertile age. The fertile age. I will tell you, in United States, we have 350 million. Let's make it 300 million. It's 320 really at this moment. 300 just to give round numbers. People in United States. From these 150 million are going to be female. From these 60 million are in this fertile age. So potentially you can have in United States about 60 million women pregnant between 15 to 44 years old, but only get pregnant 6 million every year. 6 million women get pregnant in United States every year, per year. From these 6 million people, 2 million are going to be lost by abortions. And only they are going to born about 4 million new babies. 4 million. In California, you're going to have 400,000 newborns every year. In Bay Area, you have 40,000. And San Mateo, you will have 2,000 new babies in San Mateo. So you will have plenty job with OBGYN. Okay, just to illustrate that a little bit. Okay, menarche is 12.7 years old, and here is 51.2 is the menopause. At 55, everybody is menopause. Okay. All right. So we have the FSH. The FSH, what is doing is the follicular stimulant hormone. So tell me, everybody. Me as a male, we males, do we have FSH? Yes or no? Do I have FSH?
Yes.
Yes. Do I have the lutein hormone, the LH? Male, we have LH or no?
No.
Yes, we have LH. We have LH. So we have FSH and we have LH. But was discovered first in female, so that's why the name is correlated to the menstrual cycle in female, right? But what is doing the FSH in male? The FSH in male are going to stimulate, that is in male, are going to stimulate the Sertoli cells. And the LH in male is going to stimulate the Leydig cells. What is doing the Sertoli cells? The nursing of the sustentacular Sertoli or nursing cells are to take care of the spermatozoid, right? And the ladies, what they are doing? They love
Testosterone.
testosterone. How to remember that? FSH Sertoli, LH Leydig cell. Okay? So we have, and I don't need to tell you, we as a male, we have estrogens, we have progesterone, we have testosterone, obviously. And female, they have estrogens, progesterone, and they have testosterone too. So all the sex hormones, we have it, male and female. The difference is that in male, we have much more testosterone than estrogens and progesterone. And in female, they have more estrogens and progesterone than testosterone. You okay with that?
Yes.
Okay. So FSH, write it down, produce estrogens. As very summarized. LH, ovulation. Forget about this. This is maternity. All right, so the estrogens. The estrogens are very important. I'm going to make a list that is going to be so useful for you. Okay? What are the functions of the estrogen? The estrogen, what it's going to do is, number one, the proliferative phase. Correct? We got that?
Yes.
Another function of the estrogens is to increase the production of proteins. There's more proteins in your blood. Increase proteins. Increase the number of proteins. That is very important for pharmacology. So I want to tell you all the functions of the estrogen. There's many, but the most relevant. Number three, they are going to increase the activity of the platelets. They are going to increase the activity of the platelets. So that's why if you take OCP that are estrogens, when you smoke, you produce irritation of the endothelium, so you can produce some clots. Smoking can lead into clots, right? Now, if you are having OCP, it's contraindicated, it's prohibited to smoke. Don't smoke if you take OCP or estrogens. Why? Because the smoking is going to destroy the endothelium of the vessel, producing clots. And the estrogens are activating the platelets. So it's going to be much more easier to produce clots if you're taking OCPs and smoking. And that can lead into strokes. Okay? Number four. Number four, what is number four? This is the last one. What is number four? Oh, number four is going to increase the elimination of cholesterol through the bile. Okay? So those are the main functions that I want you to remember about the estrogens. The proliferative phase, we have increased the level of proteins in blood. It's going to increase the activity of the platelets, and it's going to increase the elimination of cholesterol through the bile. Remember, what is the bile? The bile is going to be bilirubin, cholesterol, bile acids, lecithin, water, and electrolytes, correct? And the estrogens are going to help to eliminate cholesterol. So female are protect by estrogens. If you take the blood test of a female, they don't have high levels of cholesterol. Why? Because the estrogens are going to help to eliminate the cholesterol through the bile. You okay with that?
Yes.
And proof of that is that the more levels of cholesterol, you have a risk for myocardial infarction. So that's why female in fertile age, 14 to 45, they are not going to have as many heart attacks than male before that age. But after that age, the number of myocardial infarctions are going to be similar in male and female. Why? Because after that age 50s, the estrogen levels in female are going down, so they lose the protection of cholesterol, the protection of the estrogens to decrease cholesterol. You okay with that?
Yes.
Yes.
Yeah.
Okay. So write it down this, put it then very clear, please. You're going to use it very soon. That. All right, so here we have the obstetrics is the study study women during pregnancy. Pregnancy is called gestation. Pregnancy duration of a LMP is 9 months and 9 days. So I'm going to do some activity here. Okay. So what day is today? What day is today?
Wednesday.
Wednesday,
18.
18, right? Yes?
Yes.
Yeah.
Yeah.
Yes.
Okay. All right. Let's suppose if I ask you, when was okay, so let's make it more real. July. Let's make it July 10, just to make it more simple. July 10. So you are not bleeding since July 10. Are you pregnant? So when was your last menstrual period? When was the last day that you have the first day of bleeding? One bleeding. And that is going to be July 10th. Okay? You okay with that?
Yeah.
Yes.
I want to know when the baby is going to born. When the baby is going to born. So based on that data, you can tell that the patient is going to born in April 20th, 2022. Okay? So how we can get that? Very simple. From the LMP, you are going to subtract -3 to the months. And you're going to add plus 10 or 7 days to the date of the LMP. That is the formula where you can get when is going to be approximately very close by the delivery of the baby. You okay with that?
Yes.
Yes.
Okay. Now let's make some dynamic here. So let's do the reverse. When was your birthday? Okay. You do the opposite. You do +3 months minus 10 days. So that was the last menstrual period of the mother. Got it? And you will see that very common to have. When was that day? Christmas, New Year, birthday, whatever. Okay? Some Valentine's Day. All right, so we okay with that? It's clear or no?
Yes.
Okay. Okay, so what else? Okay, yeah, so basically it's that. I'm going to keep going. So what time is it? It's 11:48. So let's go 12 minutes more, and that is really going to. Okay. All right, so we have the first, all right, so one important thing here, by the way. When it's called embryo, when it's called fetus. Embryo versus fetus. But let me see, just to go into, okay, all right. The pregnancy is basically is going to be about 9 months and 7 days. 9 months and 7 days. So it's about 260 days. So 9 months is what you need to remember. Okay. Now we have here, all this is the pregnancy. We have the first trimester here. First trimester is going to be from 0 to 12 weeks. The second trimester is going to be 12 to 24 weeks. And the third trimester is going to be 24 weeks up to 40 to 42 weeks. The most common is 39 weeks delivery. Okay? You okay with that?
Yes.
Now, fetus, so embryo, between embryo and fetus, what you need to remember. Embryo is basically happening the development. And fetus mostly happen is the growth. Okay? The embryo, the heart starts to beat at 21 days of gestation. 3 to 4 weeks. 5 weeks is going to be formed the respiratory tract. 6 weeks, the GI tract. 7 weeks, the kidneys. 8 weeks, the bones and muscles. 9 weeks are going to be the rest of the body. So that is telling you basically that the first trimester is the most very important, because in the first trimester means that what is happening is that development. What is development in simple words? Development is that you are creating for the first time the organ and the functions. So it's in the first trimester where you are going to have actually the baby start forming for the first time the kidney, the spleen, the muscles, etc., etc., etc. So that is that development. What is the development? The creation. You're creating the organ and the function, the anatomy and the function. It's very critical time. Very critical time. When after that are going to be is going to be called up to 10 weeks. 10 weeks is called embryo. Basically 8 weeks. 8 weeks. Because 10 weeks is because you consider the LMP. Okay, 8 weeks. 8 weeks. So this time is called embryo. Beyond 8 weeks is going to be fetus. What is fetus? After they form all the organs and they form all the functions, the fetus start to grow in size, grow in size. So the most risky area to take care of the pregnancy will be which portion? The first trimester, second, or the third trimester?
First.
The first trimester. Okay? All right. So now, you need to be careful. This is basically an embryological age. Why? This is what is really happening. But you don't know exactly when was your fertilization. You don't know. Why? Because when we check the gestational age, you're checking based on the LMP. LMP is the first day of bleeding. But the first day of bleeding, you cannot get pregnant because there is no ovum. Actually, it's after 2 weeks of the LMP. 2 weeks. After 2 weeks. So here's where we have the ovulation. But we use this term because it's the best parameter, the best way to measure or to calculate standardize the gestational age of the mother. So that's why for these 8 weeks is the embryo. But basically, the baby is going to have for LMP 10 weeks. So up to 10 weeks is embryo. In conclusion, you consider the embryo between 8 to 10 weeks. After that, you're going to consider a fetus. You okay with that?
Yes.
Yes.
Okay.
Yes.
So now that's what I recommend you girls to plan your pregnancy. You need to plan pregnancy. You need to plan the pregnancy. Why? Because it's in the first trimester where it's happening mostly of malformations or abnormalities. So you go, for example, to a party, say, oh my God, I was drunk and I get pregnant. Oh, my baby is going to be okay. And you're going to suffer, thinking, dreaming 9 months about is the baby is okay or not. Did I did good or bad? You start to feel guilty, all right? So that's why I recommend to plan your pregnancy. One thing I want to tell you. Tell me, if you want to get pregnant, are you going to get drunk?
No.
No, right? Okay. So this substance can affect the baby. And I will tell you, during pregnancy, can you take alcohol?
You're not recommended to.
Not recommended.
It's not recommended at all. In the past, myself, I was saying, oh yeah, you can take 2-3 glasses of wine. But now, after 5 years ago, I read a journal in the New England Journal, England, very spread out, very famous, is that alcohol is not recommended at all. Why is that? Why is that? Why? Because it's demonstrated that the number of cell division of the nerve cells of the baby, they're not going to destroy nerve cells. Huh? They're taking alcohol, they are not going to kill nerve cells on the baby. What is going to happen is to have a delay of more cell division of the nerve cells. So as a consequence, you have the baby less nerve cells than should be had. So that's why we don't want to have alcohol during pregnancy at any time. You okay with that? A sip,
Yeah,
probably.
that's interesting. That's
Yeah.
interesting.
Yeah.
No, because when I was pregnant with my son, he's 22 now, they were like, yeah, you could have 1 glass of wine, but to relax you. But now I didn't know that was now.
No. Still now they say that 1 glass of wine, but not even 1 glass of wine for me is allowed. So if I will be your doctor, will say no alcohol at all. Why? Because you want the 100% of your baby, right? You don't want to have 99.9.
No, you want 100%.
You want the 100%. You okay with that?
Yes.
So now tell me one thing. So these people say, oh my God, I was in Las Vegas. Oh my God, I was in Las Vegas. Oh, now I'm pregnant. Oh, what I did now, right? So that's why I recommend you to, I'm not saying no go to Las Vegas. You can go to Las Vegas if you want. But the thing is, I don't want you or pregnant in the first trimester, especially, to dye your hair. Why? Because that chemicals can go to the baby, or no? Right?
Yes, through the bloodstream.
Exactly. For example, polish your nails. Don't polish your nails. Don't polish your nails. Don't do tattoos or whatever, nothing.
So, what about the doctors that say you can dye your hair, but just don't touch your roots?
Because that is increased absorption. When they touch the roots, it's going to increase even more the absorption. But I don't want even to take the risk that even 1 drop of something getting into the baby. Got it?
Yes. How do you feel about cannabis use during pregnancy?
Cannabis use produce malformations. The eyes of the baby are going to separate more. They have cleft palate, cleft lip. You don't want to have that. If you're lucky, probably nothing happened, but definitely the baby is not going to be in their 100%. This is for sure. Okay. Second, are you going? Why are you laughing, Aleja? Brooke?
Dr. G, I have a question.
Just a moment. I want to say something before I forgot. Ina, don't use perfumes. No perfumes. No perfumes, please.
Sorry. I'm sorry.
It's
Why
just
you-
basically anything that could go through like our skin into our bloodstream is what's dangerous, right? Because it all goes to the baby.
That's correct. That's correct. Ina, please, your turn.
So is it true that we can't eat like raw food like salmon or sushi while you were pregnant or while pregnant?
You can, yeah, because it's a risk for bacteria. And you can lead into nauseous, vomiting, and you can have electrolyte imbalance.
I
Okay?
would
And
need
that,
to be
that is
pregnant.
going to affect the electrolyte balance of the baby too. So all
And
the
that causes
electrolyte,
you to like naturally abort your baby, right?
what
if you were-
naturally abort your baby? What do you mean abort?
Like if you're in the early stages of pregnancy and let's say you get like the stomach flu and you have excessive
Yeah.
vomiting, diarrhea, your body will naturally, you lose your baby basically.
You not necessary, but it's increase your risk of loss, baby. Don't use perfumes, huh? No perfumes, because that can produce the increase of what. And by the way, they said, I want you to take your folic acid. Your folic acid. Folic acid is the vitamin B9, 40 milligrams per day. It's the prenatal vitamin. That is going to decrease the risk for neurological problems like spina bifida. Okay, you will talk that. If you want me to answer, I will explain you. Maternity, just if you want me to be a guest in your maternity, I can go there. Okay, when this module 4. What else? Oh, some people said, oh my God, I'm going to take all the vitamins in order to keep it in my body for pregnancy because I want to have a strong pregnancy. Totally wrong. Especially the vitamin A. Don't take vitamin A in excess because vitamin A can produce facial malformations in the baby. So what to do? So I cannot do anything. So what to do? What to do is listen to your body. Listen to your body. We have thousands and thousands and thousands of years of evolution. Listen to yourself, your instinct, the maternal instinct. If you need something, most likely is what you need to eat. If you want to eat radish with jam or you potato with candy, if that is what you want, that is what you need to eat. Because listen to your body is the nature who is talking towards you, through you. Okay? So I'm saying all this, especially about the alcohol and all that, because there is a risk. I'm not saying that it's going to happen. Okay? So everybody knows how is that. So I don't think anybody, if somebody did something of what I said, don't feel guilty because it's not your fault. But now is your responsibility. Okay?
Okay. And Dr. G, it's 12:03.
All right, so let's have a break, 12:30. And let me see if I finish something here. Yeah, I basically finished. One more thing. One more thing I want to tell you. This is the last one. All right, so the pure spermatozoid, and I'm going to tell you something here. Listen to this, okay? Everybody ready? For ejaculation, you have 350 million spermatozoids coming out like crazy, running like where are you going to go? Where? So 350 million running after one person. Imagine yourself, you are the ovum. Imagine you're the ovum, you're in your house, and suddenly all the United States are after you. All the United States is after you because it's the same population of spermatozoids. Okay? From this, they are going to, when the ejaculation happens, the average is going to last the spermatozoid 1 day in the vagina and surrounding. They have 24 hours in order to find the ovum in the fallopian tube. In the fallopian tube, when they found the ovum, they are going to produce the fertilization. The fertilization then, after that, they are going to go back to the uterus to make what we call the implantation. So from the day of the fertilization until the implantation, that is implantation like a plant, you put the seed on the soil to grow. And that after fertilization, the seed is going to look for a soil, that is the uterus. And that takes 6 days. 6 days. 6 days. If you are drunk or something, basically the fallopian tubes are going to be crazy, and the 6 days start, the implantation can be in different place. So you need to be careful with that. So after that, the implantation, that is the last thing I want to tell you. Implantation is when the zygote are getting deep in the endometrium. It's like you are having covered by blankets. These blankets are going to have a lot of nutrition, glycogen, blood, oxygen, etc. Okay? Now, just to finish with a last thought, and probably some of you already heard about that, I'm going to tell you again. We have 300 million spermatozoids that are getting into the uterus to find one ovum. From these 300 is a very rude, very cruel race, by the way. And what happened? From these 300 million people, all United States, everybody is going to be killed. But only one is going to be the survivor. Why? Because only one spermatozoid is getting into the ovum. You okay with that? Now, from all these 350 million spermatozoids, how many are the winners?
One.
One. And who is that winner?
All of us.
Oh,
You.
me.
You are being selected from this, out of these 350 million people. Only one survived, and that is you.
We're good swimmers.
Exactly. So now can you understand how special you are? How unique you are? How much you can do in this life? Very good. With that thought, I just finished this part, and we finish anatomy and physiology. We are going to review the next topics. And that is a very good way to tell your kids sometimes how important they are. Okay?
Oh, that was cute, Dr. G.
All right. Thank you so much. So
I'm a winner.
We're all
you are the
winners, guys.
winners. Yeah, each of us is a winner.
We should be in the Olympics.
Yes, I will win.
Yes, excellent. You are ready to do everything. Okay? All right. See you then. I will see you at 12:30 because we need to have two topics. Okay?
Thank you.
Thank you.
Thank you.
12:30. Hello? Hello, let's start. Your camera, please. All right, so let's continue. Okay, so everybody here. All right, so let's start with the eye. Okay, I'm going to make it very simple, okay? So please, but you're going to get everything that you need. Okay. Well, I would like to have the picture from right to left instead of left to right. But anyhow, okay. Let's start. All right, so please, everybody participate. How many letters we have in the eye? The word eye.
3.
Three letters. Excellent. So that means the eye is going to have 3 chambers and 3 layers. It's going to have 3 chambers and 3 layers. You okay with that? Where are these 3 layers? The 3 layers will be this one. Number 1 is this, the sclera. Sclera, that is the fibrous tissue that is basically surrounding and giving the shape of the eye, the sclera. Okay? So in other words, is the white of your eye is the sclera. We okay with that?
Yeah.
Okay. So now the sclera are going to continue anteriorly with this structure that is the cornea. That is the cornea. Cornea, so from white become transparent. It's the continuation. The cornea is the continuation of the sclera, but the sclera is going to change the characteristics. They are going to be transparent. You okay with that? The second layer is this layer here. This is the sclera is the outer layer, the white, of course. The choroid is all this red layer here. We was talking in the nervous system, the choroid plexus. That is not the chorioplexus. Chorioplexus is the one who produces the cerebral spinal fluid. But here we call the choroid membrane. Choroid membrane. What is the choroid membrane? The choroid membrane is going to have a lot of arteries and veins, so vascular. If you see here, the middle layer, who's coming? Christian. I need to invite somebody else, by the way, before I forgot. Okay? So we have here the choroid membrane that is vascular. So that is giving blood supply to the sclera and blood supply to the yellow, that is the retina. So vascular is, choroid membrane is a vascular area. So how you can make evident on that? When you take a picture, the picture you see that sometimes appear like a red eye in the picture,
Yeah.
right?
Yes.
Is because the light was getting into your eye, and basically he was taking picture of your choroid membrane. So that's why some pictures appear like a red eye. Okay, in the picture. Then we have the other layer. We have the outer layer, the sclera, the middle layer, the choroid membrane, and the inner layer is the retina, yellow. That is the retina. The retina is basically coming from the cranial nerve number 2, the optic nerve. Cranial nerve number 2 is the optic nerve. This optic nerve is coming like this. So please, I want you to use your imagination. We have like a balloon, a balloon. That is the eye. The cranial nerve number 2 is coming, and they are going to, when they get into the eye, they are going to open like a flower, like this, covering all the inner layer of the eye. Is that clear or not?
Yes.
Yes.
Okay, so that is what is the retina. The retina is the continuation of the cranial nerve number 2. Cranial nerve number 2. And this is for vision only. It's not for eye movement. Listen, not for eye movement. It's just for vision. For vision. You okay with that? Excellent. Now, in the retina, we are going to have one indentation here like this. It's going to go like this and then down like that. That is the fovea. Fovea. Okay? Now, here I'm going to ask you, did you hear about the macula? Okay. The
Yes.
macula, if you see from anterior posterior, the macula is going to look like this. That is the macula. These macula are going to have high concentrations of receptor for vision, the cones and the rods. So we have cones and rods all over the retina, but in higher concentration, we are going to have the cones in the macula. These cones, cones are going to be receptor for how sharp is your vision, and for color. How to remember that? Color cones. And the rods are going to be for night vision. The rods. How to remember? You, in the darkness, you need to use a rod in order to walk, because you don't see anything. You need to check where you are stepping on. Rods. So rods are receptors who are going to detect the light during the night. And the cones are going to be but rods can be used day and night, darkness, etc. So, but rods specifically are going to be used for night vision, the night vision. Cones are for color. How bright is your vision? How sharp, how crispy is the vision? How do you know how crispy is your vision? Because you can see the borders of the objects very defined. Okay? All right. So that is the macula. But in the center of the macula, we are going to have the fovea. The fovea. So this is the fovea. So we have the macula, that is an area we have higher concentrations all over of rods and cones, but even more in the center, in the fovea, is where we have the highest number of rods and cones. You okay with that?
Yes.
You okay with that?
Wrong hand.
Sorry? A question? Okay. You want me to repeat that? Somebody said that or what? Please, time. Nobody told me anything? Okay. So now, the entry of the optic nerve, that is for vision, is going to get into the eye. This area is called the optic disc. The optic disc. All right, so that is about the layers of the eye. So we already know that we have 3 layers: sclera, choroid, retina, and the details that we was talking. Then we have the 3 chambers. But before to get into the 3 chambers, you need to know the structures of the eye. Number 1, we have the cornea. Let's go from anterior, posterior. From anterior, then behind. So the cornea. Then we have this area that is called the anterior chamber. Anterior chamber. This anterior chamber is going to go from the cornea to the iris. Can you see the iris here? This is the iris. Iris. So from here, from the cornea to the iris, all this is the anterior chamber. Okay? All right? Then we have here, posterior to that, we have the lens. The lens. These lens are going to make, is going to be more wider or more narrow when you are going to do the focusing of your eye. When you are focusing on the distance or focusing very close to your eye, so the lens is going to change shape. It's going to change shape. Okay, so for this, I'm going to tell you that we have, that belongs to the posterior chamber. Posterior chamber. The posterior chamber go from the iris to the lens. So all these from the iris to the lens, all this is going to be the posterior chamber. The posterior chamber. So we have anterior chamber, and we have here the posterior chamber. You okay with that?
Yeah.
So
Yes.
you need to remember that the anterior chamber go from the cornea to the iris, and the posterior chamber go from the iris to the lens. So that is the posterior chamber. Then we have the third chamber, that is not called chamber, it's called the vitreous body. All this is the vitreous body. Don't get confused. This is not the posterior chamber. That is not, this vitreous body is not the posterior chamber. Posterior chamber is between the iris and the lens. This chamber is called the vitreous body. The vitreous body. We are okay with that?
Yeah.
Now, thank you. So the vitreous body is a fluid that is jelly, a jelly fluid, gel. Question for the exam. They are going to help to have the shape of the eye. So who is helping for the shape of the eye? Is the sclera, the outer layer, and the vitreous body. That is gel. It's not liquid. It's not like water. It's gel. Okay? Okay, perfect. Now, let's start. Now, in the posterior chamber here, in the posterior chamber, this is the posterior chamber, we have a structure that are going to be called this area and this area. Remember, I want you to use your 3D imagination. So this is a cut, but this is a circle, like a circumference. So it's going to be like a ring all over. So this is called the ciliary body. The ciliary body. The ciliary body is composed by three structures. Again, number three. Number one, the ciliary muscle, and the ciliary muscle is here. The ciliary muscle, this is the ciliary body here, and the ciliary muscle send muscles to the lens, muscles to the lens, and these muscles are going to pull or relax. They are going to contract or relax, making the lens to make more wider or more narrow, and that ciliary muscles are going to help to focus if you want to see in the distance or want you to focus on the near to your eyes. So the ciliary muscle. Then we have the ciliary vessels. Those are vessels, arteries, and veins. And the third one is the ciliary gland. Very important. The ciliary gland. The ciliary gland is going to produce the aqueous humor. The aqueous humor. The aqueous humor. This aqueous humor, please listen to this. The aqueous humor, who produces the aqueous humor? The ciliary gland. The ciliary gland. That is part of the ciliary body. These aqueous humor are going to go into the posterior chamber and into the anterior chamber. That is the location of the aqueous humor. That is going to be the location of the aqueous humor. You okay with that?
Yeah. Yes.
Okay.
Yes.
So now, here we have, so this is very important to remember for one reason. And I'm going to apply everything that we learn right now. So please remember the pupil is going to be the entry of the light. So this is an opening. That is the center of your eye. Iris is the color of your eye. The pupil is the opening that is in the iris. Okay? That is, iris can be dilated or contract. Okay, perfect. So one thing I want you to remember is about glaucoma. 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 Glaucoma means that you are actually have the intraocular pressure is going to be increased. What is the problem here? Glaucoma, with the time, you can get into blindness. These glaucoma are going to be they are going to be the cause of blindness of the patient. Okay, glaucoma. There is two different types. I'm not going to go on that. So intraocular pressure. The intraocular pressure will be 10 to 21 millimeters of mercury. When you go to the optometrist, they are going to measure the pressure of the eye. What is the problem and why glaucoma can produce blindness? What happened is that the glaucoma is going to have an increase of the intraocular pressure, IOP, is an increase of the intraocular pressure. And why is increased? Why? Because you have excess of aqueous humor. Aqueous humor. Who produces the aqueous humor? The ciliary gland. Where is the ciliary gland? In the posterior chamber. Where is it? Here. Here. Remember 360, right? Because it's around, this is just one cut. Okay, so what happened with this excess of fluid in the anterior posterior chamber? This anterior posterior chamber, what they're going to do is to produce a big pressure back. They're going to make a pressure. They're going to push the vitreous body and they're going to basically strangulate the optic nerve. They're going to basically pressure on the optic nerve. That pressure in the optic nerve are going to make die one by one all the nerves that are composing the optic nerve. So nerve by nerve is going to die and die and die and die because too much pressure. Why? Because you have excess of aqueous humor. And that can produce blindness. Is that clear?
Yeah.
Yes.
Okay, thank you. All right, so that is the aqueous humor. And what we need to remember about this is this, that this aqueous humor is going to be produced by the aqueous humor produced by the ciliary glands, and this fluid is going to be here. But this fluid is going to be drained. It's going to drain out, drain. And this drainage is going to show you here. Let me see if I have it here. No? Ah, okay. No, it's too difficult picture there. Okay, so, all right, so let's keep it this. We have here a channel. This channel is the escape of the aqueous humor. In this area, we have a channel. This channel is the escape of the aqueous humor. This channel is called the Schlemm's canal. So if you have excess of aqueous humor, so you have aqueous humor, normally they're going to go out in order to prevent increase of the pressure of the aqueous humor in the eye. So this Schlemm's canal is where it's going to drain the aqueous humor. When this Schlemm's canal is blocked, they can produce increase of intraocular pressure. Or the other option is when the ciliary glands produce excess excess of aqueous humor. So there's two options that are going to happen, the intraocular pressure. Number one, excess production of aqueous humor, or decrease the drainage of the aqueous humor. That is the basic thing that you need to remember when we are going to talk about glaucoma in MedSearch 1 and pharmacology. Okay? Now, we have a nerve here that is the optic nerve. Remember the cranial nerve number 2. Second, we have the other thing I want to tell you is this. You need to remember this, please. So it's to, okay, this. Here, we have the pupil are going to be this size, normal size. Normal. The pupil are going to be like this. Is dilated, that means mydriasis. And the people, when this is small like this, very small, that is called meiosis. This is very important. Why? Because mydriasis, they are going to be increased when you have pain, when you are in pain, because basically this is the sympathetic nervous system. And meiosis is the parasympathetic nervous system. Mydriasis is going to be dilated in cases of head trauma, when you have bleeding, head bleeding in the head. You have mydriasis when you're taking drugs like amphetamines, like cocaine, like marijuana. You're going to have mydriasis. Meiosis is going to be the opposite. It's basically when you have a cholinergic activity. So there are going to be meiosis. And meiosis are going to be like this, pinpoint when the patient is using opioids, morphine. So it's very important to check the eyes, the mydriasis, the pupil, because it can mean many things. Okay? Mydriasis, drugs like cocaine, marijuana, head bleeding, blood in the brain that produces mydriasis. Meiosis are going to be when basically you have opioid intoxication. Now, one more thing I want to tell you here is this. The rods and the cones. The rods are part of the retina. Higher concentration in the macula, even more higher in the fovea. Where is the fovea? The fovea is the center of the macula. If you have the macula, the center of the macula is the fovea. And here we have higher concentration of that. We have rods and cones. The rods are for night vision, and the cones are going to be for color and sharp image. Now, question for the exam. We have the vitamin A. The vitamin A. The vitamin A is to regenerate and maintain the rods. Vitamin A is the deficit of vitamin A can produce night blindness. Night blindness. So, conclusion, vitamin A, nothing to do with the cones. Nothing to do with the cones. Vitamin A is only going to be used for the rods. Is that clear?
Yes.
Yeah.
Now, I want you to remember this number, 3, 4, 6. Can you remember that? 3, 4, 6, 3, 4, 6, 3, 4, 6, 3, 4, 6.
3, 4,
Yes.
6.
3, 4, 6. Excellent. These 3, 4, 6 are the cranial nerve 3, 4, and 6. 3, 4, and 6. So we have the other cranial nerve 2, that is for vision. Question for the exam. The cranial nerve 3, 4, 6, that we will learn the names in the next, are going to be for eye movement. Eye movement. This is not for vision. 346 is not for vision. It's for moving the eye, to move the eye, the mobility of the eye, okay? We have two types of muscles. The intrinsic muscles that are going to be the iris. Intrinsic means inside the eye. And we have the ciliary muscles. And the extrinsic muscles are going to be these, who are attached outside of the eye. We have the superior rectus, etc. I don't want you to remember the names. Just remember that we have muscles that are going to move the eye in different directions. That are the extrinsic muscles. Okay? The extrinsic muscles are going to be obey to the cranial nerve 3, 4, and 6. Is the eye movement. You okay with that?
Yes.
Okay, so let's talk about now. That is all about the eye. I want you to talk about the ear now. All right, so let's talk about the ear. Okay, so can you give me 10 more minutes, please? No? Hello?
Yes.
Hello?
Yes.
Okay.
Please.
Yes.
Yeah, because okay. All right, so here we have the ear canal. I'm going to make it bigger. I'm supposed to have it there already. The cranial nerves are going to be very easy, but I need to finish this, please. The ear. Okay, so you have the ear here, and the ear, you have your ear here, is called the pinna. Pinna. This is the ear, and you know, the ear is going to be like, the shape of the ear is to collect the sound waves. You're going to collect the sound wave. Now, please, experiment. I want you to do, can you hear me now? Can you hear me? Yes or no? Can you hear me? Can you hear me? Yes.
Yes.
I want to
Yes.
put your hands on your ears like this, like this. Okay? Can you hear me? Can you hear me?
Yes.
Yes.
Less. Yes. Louder.
What do you mean less? Louder.
Louder. I hear you
Oh,
louder.
okay, loud. Okay, louder. Okay. Louder. So why? Because you are collecting more wave sounds that is getting into your ear. We have the ear. How many letters we have in the ear? 3 letters. So we have 3 compartments. 3 compartments. We have the outer ear, we have the middle ear, and we have the inner ear. Okay? Outer, middle, and inner ear. The outer ear go from the pinna to the tympanic membrane. There you are. Pinna, and that is question for the exam. Where is the outer ear from the pinna to the tympanic membrane? Then you're going to have the middle ear. The middle ear is this. This is the middle ear. That's it. The middle ear. That is the middle ear. It's in the middle of the ear. And what we have here are going to be called the ossicles. Ossicles. Those are bones. These ossicles are going to be 1, 2, 3 again. 3 is everywhere here, right? Now, the outer ear, just to rephrase, outer ear is composed by the pinna, 1, the ear canal, 2, and 3, the tympanic membrane, 3. The middle ear is going to be composed by 3 bones. The malleus, 3 again, malleus, incus, and stapes. Malleus, incus, and stapes. Malleus, question for the exam, is the hammer. The incus is the anvil. Is the same name. And the stapes are going to be called the stirrup. How to remember that? Miss bones. Miss. M. malleus. Hammer is the only who has M. Hammer, M. incus, incus. This is the only one who have the IN, ambil, incus. And stapes is the only one who have T, stapes and stirrup. Okay? What is the function of the function of these ossicles? Remember, they call ossicles. Ossicles are these three bones. Okay? Middle ear, middle miss, malleus, incus, stapes, middle ear. Okay? Now, what is the function of the ossicles? The function of the ossicles is to amplify the sound wave, amplified 20 times. 20 times. So what happened? The vibration is coming here, the sound is coming, they're going to vibrate. This vibration is going to make vibrate the malleus. This is the first one, malleus, mis, M. This malleus is going to make vibrate the incus or ambil here. And the other bone here is the stapes of the stirrup or the stirrup. So what they are going to do is to increase the sound wave like this 20 times so you can hear better. So when you get older, there is kind of the articulation between these bones are going to be harder. So you don't know, you are not going to have that vibration. So you are start to losing your hearing when you get older. Okay? In addition, the middle ear is going to contain this tube. This the eustachian tube or auditory tube. The eustachian tube. This eustachian tube is connecting the middle ear with the pharynx. When you have, very common is to have a cold or a flu, the virus that is in your pharynx are going to travel all the way through the eustachian tube or auditory tube, and they are going to infect the middle ear. So that's why the most common ear infection is the middle ear infection. Middle ear infection. Is that clear?
Yes. Dr. G, I have to get off the call. I'll finish watching the rest, but I have to go take my drug test for skills.
Okay, dear. Thank you for giving me that chance. Thank you so much.
Thank
Okay. Okay. So now, that is the middle ear. You okay with that? Now, here we have going to enter into the inner ear. The inner ear are going to be composed, again, by three structures. The inner ear. Inner ear, this is, what happened here is the, this is, can you see like a snail here? So this is the vestibule, the vestibule. This is the cochlea, and this is the semicircular canals. So how many? Three of them. Semicircular canal, the what? The vestibule and the cochlea. Now, this cochlea, vestibule, and semicircular canals are like a hollow organ. It's a hollow organ. This hollow, see, if you see here, we have the middle ear connecting to the inner ear. We have the vestibule. It's like getting into a building. You have into the building, you go to the vestibule, and then you have two options: or go to the semicircular canals, or go to the cochlea. So what is inside of this inner ear? Inner ear, we have fluid. This fluid is the inner ear. What is that? The endolymph. It's called the endolymph. Yes, it's fluid. It's fluid. Now, imagine you have a plastic with water. Big plastic with water. And then you hit the water, you hit with your hand here. So what happened? Waves are going to be formed or no? Yes? You follow me? Yes or no?
Yes. Yes.
Now the vibration of the ear is coming here, the wave sound, they are going to hit the tympanic membrane. they're going to amplify 20 times the vibration, and this vibration is going to hit the inner ear that is being filled with fluid. This here that is hitting the by the stirrup, by the middle ear here, the vibration is going to continue with this fluid. This fluid is going to be moved by the vibration, and they're going to create waves inside the fluid of this inner ear. Here in the cochlea, we have receptors, cells like this, cells. These cells are going to have like a cilia, hair, like a hair. So when the vibration is coming, it's hitting the water that is inside of the inner ear, the vibration are going to start doing this through the fluid. And they're going to make the cilia of the cells to move. These movements are going to be transformed into electrical wave. So go from a wave sound that is mechanical, they are going to be transformed into electricity. These cells are going to be called the corti organ. The corti organ. Corti organ. These corti organ are going to transform the wave sounds in electricity, and then they are going to be collected by the cranial nerve number 8. That is the cranial nerve number 8 is the vestibular, there you are, vestibular cochlear nerve. So why is called vestibular cochlear nerve? Because the wave sound go to the vestibule. This is the vestibule, if you remember. Here we have the vestibule. And from the vestibule, they go to the cochlea. This is the cochlea. All this is the cochlea. Cochlea, vestibule, semicircular canal. Okay with that?
Yes.
Okay.
Yes.
Now, here we have the other one, the other place that is going to go, the wave sound, the vibrations are going to go to the semicircular canal. Again, how many semicircular canal we have? 3. 1, 2, and 3. Everything is 3, right? Ears, everything is 3. So now, what is this? If you have a bottle of water, here we have a bottle of water. This is water. What happens if I put the bottle like this? The water is going to be like this or like this? Like this, correct? Yes or no?
Yes.
Now, if you put the bottle in the other way, like this, the water is going to still horizontal or no?
Yeah.
Right? So that is important. Why? Because when you are moving your body, this fluid that is in the semicircular canal are going to detect the position of your body. So that's why when you close your eyes and you lean to the right or to the left, forward or back, they are going to, you go without closed eyes, you can tell which position is your body. And that is the semicircular canal for position, the body position, to detect the body position. So that are the semicircular canals. Okay? The last thing I want to go here is this. Tell me one thing. So if you put your finger in your ear, you have a bone here. Can you see this bone? So basically it's going to perforate the bone. Which bone is that? The temporal bone. So the ear canal is passing through the temporal bone. Okay? The middle ear is immersed in the temporal bone, and the same from the inner ear. Okay?
Yeah.
One more thing before you go is here. So here is two important things about the pinna or the auricle. The pinna. This long line is called the helix. This is going to be called the antihelix. this here we have the tragus, very important, the tragus. This is the tragus. And posterior to that, we have the antitragus. Tragus is a very important point. Why? Because if you can tell if the patient is having toothache or headache or something that is confused with earache, and mostly likely the most common cause of pain of the ear is the middle ear infection. And how you can check is a middle ear infection. You can check doing the tragus sign. You are going to pull or push the tragus, and that is going to create an excruciating pain on the ear. So if you don't push harder, push very soft, very kindly, very careful. But if that produces pain, that's most likely a middle ear infection. You okay with that?
Yes, doc.
Yes.
And the last things that we are going to talk. Just give me 4 minutes. So we have the cranial nerves. The cranial nerves are going to be 12 pairs. Okay? These cranial nerves, basically the majority is coming from the brain stem. So from the brain stem. The brain stem. So we have 1, 2, 3, 12. One is the olfactory. One is the olfactory. Olfactory. How many noses you have? How many
One
noses?
nerve.
One nose, right? Now, that is cranial nerve number 1. Then we have the cranial nerve number 2. How many eyes you have?
2.
2.
2.
All right, so that is cranial nerve number 1 and 2. Cranial nerve, optic nerve, cranial 1, olfactory nerve. Okay? Then we have 1, we talk about 2. Let's about talking about 3, 4, and 6. 3, 4, and 6 is going to be 3, 3, 4, 4, and 6. So they are going to basically indicating that they have the eye movement. 3, cranial nerve number 3 is the ocular motor nerve. Cranial nerve number 4 is the trochlea. Cranial nerve number 6 is going to be what? The abducens. So 3, 4, 6 are giving the eye movement. 3, 4, 6, 3, 4, 6 eye movement. So 1 is one nose olfactory. Number 2, cranial nerve number 2, 2 eyes. It's going to be optic nerve. Just this is for vision. Cranial nerve number 2 is vision only, not for movement. So cranial nerve 3, 4, and 6 are going to be the for eye movement. Eye movement. All right, so let's talk about cranial nerve number 5. Cranial nerve number 5, let me see here if I have a picture here. There you are. Cranial nerve number 5 is the trigeminal nerve. Trigeminal nerve. This trigeminal nerve, they have 3 branches. We are not going to talk about that, but this is important for mastication. Mastication. For mastication. For mastication. So 1 is, listen, 1 is smell, olfactory. 2 is vision. 3, 4, 6, eye movement. Do you notice when the doctor is asking, can you follow my finger? Yes or no?
Yes.
Yeah.
So
Yes.
that they are assessing that 3, 4, 6 cranial nerve. Okay? Number 5, mastication. Number 6 is 3, 4, 6, eye movement. Number 7. 7, can you use that 7? Upside down, right? 7, 7, 7, 7, 7. Look like a face or no?
Yes.
Cranial nerve number 7 is the facial nerve. What you're doing is smile. When you smile, can you smile? Is the cranial nerve, facial nerve, the cranial nerve number 7.
Yes.
Then we have the ear. Where is the ear? The ear is going to be here. Look like an ear or no? Ear. Ear, that ear is the vestibular cochlear nerve. Vestibule, so with the ear, we already talked about the ear. The vestibular cochlear nerve, that is the cranial nerve number 8. You remember 8, like the shape of the ear. Then we have cranial nerve number 9. That is the glossopharyngeal. Glossopharyngeal. This glossopharyngeal is basically, glosso means tongue. So this is going to produce they are going to, basically they're going to be the taste. The taste is going to be located here in cranial nerve number 9. How to remember? 9, look at this, 9, and this is the head, and this is the tongue. Number 9, glossopharyngeal. That is basically responsible for swallowing. Then we have cranial nerve number 10. That is the vagus nerve. I remember cranial nerve number 10, vagus, like Las Vegas. You're wandering all over. So vagus in Latin means vagus, with A means wandering, walking. And this cranial nerve is going to innervate or have attached, they're going to make work the respiratory, the lung, the respiratory, and the cardiovascular, and the gastrointestinal. The vagus nerve, very important muscle, the vagus nerve. 11 is going to be the accessory nerve. 11. 12 is the hypoglossum. The hypoglossum is the strength of the tongue movement. Yeah, it looks like it's a very kind of, but I'm going to show you now. Look at this. All right, so we have, how many cranial nerves we have? We finished?
12.
12. Olfactory. So how you can check the olfact? So listen to this. This is very important. There's the majority of these cranial nerves coming from the brainstem, except the optic and the olfactory. But anyhow, so the brainstem. So basically, when you are checking all these cranial nerves, it's like you are looking inside the brain. If these cranial nerves are working properly, there is no damage of the middle brain. You don't need CT scan, you don't need MRI, you don't need those imaging tools, because with clinicals, you can tell what is happening. So close your eyes and make them smell something. Okay, do you smell this? Yes. You close your eyes and you don't put anything in front of the nose. Do you smell this? Yes, that is lying. Right? So you are under control. You need to be sure that what the patient is telling you is true. Okay? So classically, we close our eyes and you make coffee to smell. It's up to you if you put the coffee or not. So you want to tell the patient yes or no, what they are smelling. That is the cranial nerve number 1 is working. The optic nerve, how you can check the vision. You go to the optometrist. No. You go to ophthalmologist. No. To check, this is taking like 2-3 minutes if you do properly. So optic nerve vision, you ask the patient, okay, how many fingers I have here? 5. How many fingers now? 3. All right, so you're looking. You are not checking for the acuity of the vision. You are checking if the vision is present or not. Cranial nerve number 2. Number 3, 4, 6. Oculomotor, trochlea, and abducens. You're going to ask the patient to do this. Can you see my face, or I'm too low?
We can see it.
We can see it. We can see it.
3, 4, 6. You're going to ask the patient to do this. 3, 4, 6. Up, down, right, left, up, down. So it's like a cross. So that is checking the 3, 4, 6. So these cranial nerves are doing okay. Trigeminal. Trigeminal. Can you ask the patient to chew? Do this. Or you can do this. Open your mouth. So that you see the strength of the muscle. That is the trigeminal nerve. Trigeminal nerve. Trigeminal nerve. How you check the facial? Can you smile? Can you frown your forehead? Yes. So the cranial nerve, and you need to do the right and the left symmetrical, because one side could be the problem, the other side will be okay. So they need to be same. What's happening on the right, happening on the left. The vestibulocochlear. How you check the vestibulocochlear? You're going to do this. Do this, please. Now, do this with your fingers. And put it close to your ear. Can you hear that?
Yeah.
All right. So that is the way that we check the vestibulocochlear. So you are listening or not, hearing or not. Yes, enough is this. Do this in between your fingers. And that, if you hear that, you can do this, not do anything. Can you hear that? No. Now, yes. Can you hear now? Yes. So that is, you need to know that the patient is telling you the truth. Number 9. Number 9, the glossopharyngeal is going to be, basically, the glossopharyngeal is going to be, you ask the patient to swallow. Can you swallow? Yes, I can swallow. Is the glossopharyngeal. Glossopharyngeal is part of the taste too. Now, vagus nerve. Vagus nerve is going to be a nerve that is wandering from the brainstem, go to the respiratory, to the lungs, to the heart, and to the whole GI tract. The vagus nerve is going to release acetylcholine, the parasympathetic. All these are parasympathetic. The vagus nerve are going to be, they can produce vomiting. So how you can check the vagus nerve? You're going to ask the vagus nerve to actually open the mouth, and say When you say the uvula, that is the small bell that is behind your mouth, is doing this. They need to move symmetrically, not like this, symmetrically. Now, if there's another way that you put the small stick, or how you call this, like under the tongue, how you call that?
Tongue depressor.
Sorry?
The tongue depressor?
The tongue depressor. You put the tongue depressor and you push the tongue down and produce nauseous. That is the vagus nerve number 10. So now, if you are drinking, you are going to drink and you get drunk and you want to feel better, you put your fingers, 2 fingers, and put it all the way down to your throat. And you're going to touch the vagus nerve. Well, it's there, but it's on the walls, right? If you don't see it, but you push in the vagus nerve, and that stimulates the vomiting. So the vagus nerve is vomiting, okay? Vomiting, or the and the uvula is moving. Uvula, if somebody doesn't know what is uvula, U-B-U-L-A, uvula, is the small bell that is behind on the throat, okay? Accessory. The accessory nerve is 11. So that is when you shrug your shoulders. You said the accessory nerve is when you said, I don't care, I don't care, I don't care. That is the accessory organ. is I don't care. I don't care. Okay? So you put your hand here on the shoulder and you ask the patient to shrug the shoulder. And then with the same hand, go to the other shoulder. And the same strength should be occurring in both right and left. That is the accessory nerve. And then we have the hypoglossal nerve. That is the last thing. Hypoglossal nerve is that you need to measure the strength of the tongue. How you can measure the strength of the tongue? Somebody? Sorry, Jessica. The strength of the tongue, you're going to do this. Everybody do this. Put your hand on your cheek and push with your tongue. Put the same hand on the other cheek. The same hand, I said. Same hand. Okay. On the other cheek and push with the tongue. Should be the same strength. So that means you are normal. Okay? So that is the video. You please check the video several times. Just review, review, review. And this cranial nerves is always important to know. With this, officially, I finish, or we finish, with all the effort, with all these weeks of no sleeping, stress. You made it. We finished our course.
Yay!
Okay? All right, so now the next step is that I'm going to do the Super Sunday on Saturday. Okay? So it's going to be...
6 a.m.
It's Super Saturday, right?
Yes.
It's going to be Super Saturday. The Super Saturday will be start at 6 a.m. in the morning until 10 p.m. No. 10 a.m. 10 a.m. Only 10 a.m. I wish I could do it. 10 a.m.
It's Super Saturday.
It's going to be Super Saturday now. Okay?
Thank you, Dr. T.
Muchas gracias. I will see you in the final exam. Oh, by the way, don't go. I need to talk about, I need to talk to Mr. Verdad about the incidents of the, you received that email? You received the email or no?
Yeah, of the COVID?
Yeah.
Someone got COVID?
Yeah. So we need to evaluate the situation and we are going to give you an answer. So please don't think too much about that. I'm going to email you on time in order to know what is our
plan. What's the plan?
The plan. Exactly. Very good. Okay? Okay.
Thank you.
Gracias.
Muchas
Thank you,
gracias.
Thank you so much, Doc. Thank you, everyone.
Thank you. I will see Saturday. Gracias. And remind me, please, because my head is everywhere. So just remind me if I don't. But definitely, yeah, Saturday, 6 a.m. to 10 a.m.
Muchas gracias.
I'm going to stay until the end if somebody wants to talk to me. Okay? Muchas gracias. Have a good day.
Thank you.
Thank you. Can I please, can I buy